IAPMD. We're really excited today to have Dr. Benicio Frey with us to share some of his work. Dr. Frey is a physician, a psychiatrist, and a scientist who's currently a professor at the Department of Psychiatry and Behavioral Neurosciences at McMaster University, academic head of the Mood Disorders Program, and medical director of the Women's Health Concerns Clinic at St. Joseph's Healthcare. Dr. Frey has more than 250 articles published in peer-reviewed journals and has been a major contributor to the fields of biological psychiatry and female mental health. So welcome to you, Dr. Frey, and thank you for sharing your work with us. I'm going to go ahead and turn it over to you now, and I'll be back at the end to help field questions.
Excellent. Thank you, Tori and Laura, for the kind introduction and also the invitation to be here. When Tori introduced me to the International Association for Premenstrual Disorders last year, I was really amazed with the great work that you folks are doing with this society. So I became a lifetime member now, and I encourage everybody to become a member as well. And, so we cannot do patient advocacy enough and educational activities enough. So it's a really pleasure to be here with all of you today. And I will try to share my screen now and see if my slides work. Can someone just tell me the slides are working, please?
Yes, we can see.
Okay, perfect. Thank you so much. So I chose the title to, hope to bring, some live discussion about this important topic that is largely neglected in the medical field. So I'm calling hormonal sensitivity across reproductive life stages. Why bother? So I have no conflicts of interest to declare. So these are our learning objectives of today. I hope to review and discuss the biological studies on hormonal sensitivity and reproductive mental health, also the clinical studies on hormonal sensitivity and reproductive mental health, and also review and discuss the literature of premenstrual worsening as a comorbid condition versus exacerbation of other disorders. I'm really interested in the comorbidity aspect of PMDD. Review the link between the menstrual cycle and suicide risk and behavior, and also discuss at the end some of what I think are some educational and health service and research gaps in this area. So first of all, even though I'm using sometimes the word female and women, I want to acknowledge that a lot of individuals that don't identify themselves as women or female might also suffer from some of these conditions. So here I'm taking a biological approach as, those who have been assigned as female or women at birth. And that's how I'm approaching the word, female or women throughout this presentation. But a very important point is that a large percentage of those individuals experience major mood and anxiety problems that are associated with their reproductive life events. Here I'm just listing a few of them: menarche, premenstrual period, ovulation, pregnancy, postpartum, perimenopause, early postmenopause. But there are other, related areas as well, like when people develop certain conditions that are related to their reproductive life. But how big are these problems? So if we take a conservative approach and we look at conservatively at the prevalence rates, PMDD affects between 1.3 and 6.4% of the population. So if we agree that bipolar 1 disorder, mania, is a very important, public health concern, it affects 1% of the population worldwide across cultures. If we agree that schizophrenia is a major public mental health problem, it affects 1% of the population. If we agree that OCD is a major public health concern, it affects 2% of the population. So I would argue that condition that affects 1.3 to 6.4% of the population should receive at least the same attention, but it hasn't. What about the perinatal aspects of mental health. So I'm listing here an area that I've been actively involved, which is perinatal anxiety. Most people hear about postpartum depression, but perinatal anxiety is also a big problem. Look, these are prevalence rates of studies that did psychiatric assessment. So these are conservative numbers. If you look at studies that use just clinical questionnaires, the rates are even higher. So conservatively, anxiety disorder in pregnancy or in the postpartum period affect between 10 and 15% of the population, which is really, really high. Postpartum depression, if we are conservative, affects about 1 in 7, 1 in 10, which is about give or take 10%, which is also a pretty high percentage. If we look at perimenopausal depression, a study from the US that did the SCI, this formal psychiatric assessment, found high rates of depression in peri and postmenopausal individuals, to the rates of close to 10%. So these are all very high prevalence rates of major anxiety and mood issues that can happen, at specific times across the reproductive life stage. And I think these are strong numbers to make a case that, these conditions should be, attention should be given to these important clinical conditions. So hormonal sensitivity. Hello? Okay. So hormonal sensitivity. Research clearly shows that mood and anxiety symptoms are triggered by fluctuations of ovarian hormones, but in those individuals who are susceptible, not in all of them, as we know. So this is a major study done by Dr. Peter Schmidt, Dr. David Rubino, and folks from the behavioral endocrinology section of the NIMH that really showed that these symptoms are triggered by the manipulation of estrogen and progesterone. So for instance, here is a cartoon showing individuals with PMDD. The term PMDD did not exist back in 1998. So if you read the paper, you see that these individuals, they met criteria for what today we would call PMDD. And these individuals receive an injection of leuprolide for 8 weeks. So leuprolide blocks the hypothalamus, hypophysis, gonadal axis, so blocks the HPG axis, causing quote unquote like a chemical menopause, shutting down the ovaries for a while. Why did they do that? Because even when we administer hormones through oral contraceptives or patches or gel or whatever, we most often than not, we don't block the HPG axis 100%. So they wanted to block the individual's HPG axis so they could manipulate the estrogen and estrogen and progesterone by giving them a pill. So for 4 weeks, they were kept on the leuprolide and received estrogen pill. And then the symptoms of PMS got worse. Here you're seeing sadness, but other symptoms also worsen in that paper. If you read the paper, you'll see that. And then they cross over from estrogen to progesterone, and then again, the symptoms got worse. However, they did the same treatment in individuals, I don't like the term normal here, folks, individuals that did not have a history of PMDD, and then look, nothing happened. So what's the conclusion of this study? That in those individuals with severe PMS, today we call PMDD, the occurrence of the symptoms represent an abnormal response, I would add brain response, to normal hormonal changes. There's been tons of research trying to find what are the right or wrong estradiol level or progesterone level or LH level, FSH level, and they really couldn't find abnormal absolute level of hormones. These individuals, they have regular menstrual cycles, they can get pregnant normally, they have a normal sexual life, so there's nothing wrong with the levels of their hormones. It's their brain that once a month react to that physiological hormonal fluctuation. So the same group 20 years later answered a second question that couldn't be answered in that first study, where they capped these individuals on leuprolide, blocking the HPG axis, and then they use placebo for a month, and then they were blindly switched to now a combination of estrogen and progesterone together for 3 months. And then on the left side, you are seeing the results of self-rating scores, so how the individuals, the study participants rate their symptoms themselves. And on the right side, you're seeing clinician-rated scores, how the clinician rated the scores based on interviewing the same research participants. And regardless whether it was self-report or clinician-rated, they found that the symptoms got worse when they started the hormonal treatment. But as the hormonal treatment was kept the same, the symptoms eventually got back to the baseline, got back to normal. So they not only replicated their previous study showing that the delta, the switch, the change from no hormone to hormone trigger worsening of symptoms, but they also now answer a question that it's not the use of the hormones themselves, but it's the delta, because if you keep them on the same treatment, then the symptoms disappear and go back to the baseline. And then the same group did a different study in a different model. They tried to model postpartum depression here. So they recruited individuals with a history of postpartum depression and no other mood disorders. They should have been euthymic or stable for at least a year without treatment. So you can imagine how hard it was to recruit for that study. No wonder the sample size is so small. But they gave those individuals the same injection, blocked the HPG axis, and then they gave supra-physiological levels of estrogen and progesterone. These are very high levels to mimic the third trimester of pregnancy. And then they suddenly switched them to placebo to mimic what happens once the placenta is out after childbirth, with a sudden drop in estrogen and progesterone levels. And what happened is that only individuals with a history of postpartum depression, the symptoms got worse in the withdrawal phase, but not in the individuals with no history of postpartum depression. So this difference here is absolutely not significant. So let's talk a little bit about menopause now. So this is a cartoon showing something that we know for a long, long time. So if 0 is the last menstrual cycle, minus is the premenstrual phase, and then plus is the postmenopause. Not premenstrual, I meant to say the premenopausal phase. Premenopause, postmenopause. So if 0 is the last menstrual cycle, so that period right before the last menstrual cycle, which on average is 2 to 3 years, could be more, could be less, but let's say give or take about a couple of years long, while estrogen levels are dropping, estradiol levels are dropping, and FSH levels are increasing. If we put a microscope here in this a transition here in the perimenopause period, you'll see that these lines are absolutely not flat. So what you're seeing in front of you here is 180 days, so 6 months of daily hormonal levels. 6 months of daily hormonal levels in perimenopausal individuals. So if you're seeing here estrogen in the square, the white square, you can see that some periods it's a little higher, and then it goes low, it goes higher, and then it goes low, and it goes really high, and then low, high, low. So you lose that nice, menstrual cycle predictable that hormone dynamics. And at the same time, you can see that even in the perimenopause, sometimes the ovaries are producing a lot of estrogen and sometimes not producing at all. Progesterone here in black is the same story, so high and then low, and then a little higher and then low, and then so you lose that nice luteal phase, dynamics of progesterone rise in the perimenopause as well. And it's that delta, it's that chaotic up and down in the hormones that happen in the perimenopause that is presumably behind some of the risk in some people that are sensitive to that hormonal fluctuation that I'm calling here hormonal sensitivity. So here are many, many large longitudinal multi-million-dollar funded studies that looked at, risk of perimenopausal depression across the transition to menopause. There are, at least 4 or 5 independent studies showing the same thing, that perimenopause is a period of increased risk for depression. And then when they looked at risk factors for perimenopausal depression, many are risk factors for depression in any time in life, like negative life events, financial problem, poor social support, prior history of depression, anxiety, and so on. But what is cool for us here to discuss is that one of the studies, the Alan Freeman study here, found that was the variability, the standard deviation of estradiol and FSH, and not the absolute levels. There was actually an independent risk factor for depression in this population. And then Peter Schmidt and folks from IMH did the third model. So I showed you the perimenopause, I showed you the postpartum, and now the menopause model. So they recruit individuals with a history of perimenopausal depression and a group of individuals with no history of perimenopausal depression. They treated all of them with transdermal estradiol for 3 weeks, and then they randomized them blindly to remain on the estradiol or be switched to placebo patch. And then again, the results are very similar. So in the circle here are the people with a history of perimenopausal depression that got switched to placebo. And in the switch, in the delta, they got worse. The depression scores got worse. But doing the same treatment, the square here, in individuals with no history of perimenopausal depression, nothing happened. And then the triangle here are people with a history of perimenopausal depression that was capped on the estrogen, and then nothing happened. So again, this is yet a third model in a different population showing that some people are vulnerable to this hormonal fluctuation and some people are not. So I hope I was able to show you a little bit of more details, some of the important biological studies showing the link between hormonal manipulation and mental health reaction, like mood reaction in this case. And let's talk a little bit more about the clinical aspects of it. So one of the aspects that I said I'm very interested in, my group here is very interested in, I know Tori is also very interested in, is the issue of comorbid conditions. So people with PMDD, for instance, and other comorbid conditions, because that's where much of the challenge is for non-trained professionals. So this is a study from Germany that what they did, this is a community sample. This is not like a tertiary care university sample studies. They went to people's houses and they did the skid in those individuals. Then they went back 4 years later and redid the skid to look at the consistency of psychiatric diagnosis across time. So when you see PMDD, here's PMDD retrospectively diagnosed. This is not people that had confirmed PMDD with 2-month prospective chart. But these individuals that are retrospectively confirmed, diagnosed with PMDD compared to those with no history of PMDD had a much higher odds ratio, much higher risk of also meeting criteria for other psychiatric conditions like mood disorders, and PTSD in fact was the highest one in this study, but see bipolar disorder also very high. Then that's in Germany. So this is southern Brazil in Pelotas city, also a population-based study. Also here individuals with PMDD were retrospectively, not prospectively confirmed, but those with retrospective PMDD diagnosis, large sample, were also found to have more risk for other psychiatric conditions, including convergent suicide risk. So study done in a different culture and different country showing exactly the same results. This is a study that we done looking at one of the largest databases of individuals with bipolar disorder. They had the PMDD questionnaire there. So we looked at those retrospectively diagnosed with PMDD and comorbid bipolar disorder. And we showed that those with the comorbid PMDD had again greater rates of other comorbid conditions. These are all individuals with bipolar disorder, and those with PMDD had even more risk of other psychiatric conditions, much like what we saw in Brazil, much like what we saw in the German population. And what I found was the most intriguing result of our study was that those with bipolar disorder and comorbid PMDD had a shorter gap between the menarche and the onset of PMDD, of bipolar disorder, suggesting menarche as a potential trigger for this population here. Again, talking about the hormonal sensitivity. I found this result like really, really intriguing. So that's the US. So I showed you Brazil, Germany, US. So let's travel to Taiwan. So this is a health insurance research database, like one of those large health database studies. So they looked at individuals that had a retrospectively diagnosed of PMDD, no diagnosis of mood disorders, and they followed these individuals over time for 10 years. And there were much higher rates of development of both bipolar disorder and unipolar depression in those individuals that also had a retrospective diagnosis of PMDD compared to no PMDD. So no matter how you look at, no matter which country you're going, the link between PMDD and other comorbid conditions seem to be really strong. So now let's talk about suicide risk and behavior. So this is a study of, this is not about PMDD, this is not about diagnosis, this is about suicide and menstrual cycle. So this is a suicide research journal, and they were interested in, they pulled the studies that had suicide behavior and had also the information on the menstrual cycle phase of those individuals. So they knew where in the menstrual cycle phase these individuals were. So 32 studies, more than 3,000 people, pretty large systematic review and meta-analysis. So as you can see, there was a 26% greater risk of suicide deaths at menstruation phase. So deaths, this is not, we're not talking about ideation, we're not talking about plan, we're talking about, completed suicide. Greater risk of suicide attempts also at menstruation, greater risk of psychiatric admissions at menstruation, and great risk of psychiatric admissions at the premenstrual period as well. However, these risks were not elevated in those individuals using oral contraceptives, which may or may not suggest some protective factor here as far as oral contraceptives and risk of suicide in these studies, but very intriguing nevertheless. Then our dear Dr. Eisenlohr Mo here published a really nice study on individuals with both a PMDD and PMDD with psychiatric comorbidities versus those with PMDD alone. And as you can see, the prevalence of self-injurious thoughts and behavior in prospective confirmed individuals with PMDD is very high. So look at the numbers. Look from passive suicidal ideation all the way to being hospitalized by these thoughts are very high in this population. So we need to talk about, we need to address that. We need to tackle the stigma and make sure that we discuss suicidal ideation and self-injurious thoughts in this population as well. Not surprising, the rates were perhaps not statistically, but numerically higher in those with comorbid psychiatric conditions. And then my group here, this was my former master's student who is now in the UK in the Oxford University doing her PhD, Divya. So Divya reviewed the suicidal risk in those who had, diagnosis of PMDD or PMS. So we looked at, clinical diagnostic clinical studies here. And so 13 studies, and you're seeing the range of the sample size of the studies here. We found that in those with a PMDD, there were 4-fold greater risk for suicidal ideation and 7-fold risk of suicide attempt. And in those with PMS, the individuals that did not quite meet criteria for PMDD, there was a greater risk for ideation, but not suicide attempts. So again, I'm showing you 3 different studies looking at the link between menstrual cycle and risk for suicide and suicidal behavior very differently, and all of them converge to the same message that it's an important point to consider and track and treat, of course. Now, the next part of my talk, I want to talk a little bit about some of the clinical challenges in terms of patients not fitting the DSM or ICD diagnosis, if you will, in Europe. I'm bringing here, I copied and paste this section of the postpartum depression New England paper from Simone and Donna Stewart. In clinical practice and clinical research, postpartum depression is variably defined as depression that occurs within 4 weeks after childbirth, 3 months, 6 months, up to 12 months. So really, we all know that the definition of 4 weeks after childbirth is really not appropriate for postpartum depression. But why is it still being used? Why haven't we had power enough to convince people that are creating these classifications to change that? And then I came across Tori's amazing study that like almost caused me a relief seeing this different subgroups and trajectory individuals with premenstrual disorders, because I'm seeing those cases here in the clinic and they don't quite fit always the DSM, but I'm seeing the hormonal fluctuation in their tracking sheets, and I'm going, oh my God, so what is this? How can we classify them better? Or how can we improve, even the educational people, knowing that, even those that don't quite fit the DSM, they have also, a lot of people also have major hormonal sensitivity. They need help. They need assistance, but sometimes they don't quite fit those, artificial diagnoses. And then you can see the trajectories, the different trajectories of individuals with significant, premenstrual mood issues and anxiety issues that have a variable trajectory in terms of when the symptoms start and when the symptoms subside across the menstrual cycle. So how about some clinical cases? Let's see, some real cases here. So way back when, you can see October 2012, so 11 years ago, we got this paper accepted. So my colleague here, Dr. Minuzzi, and I, we're seeing a lot of people with bipolar disorder and PMDD. And then we were interested in understanding how to treat them better. And we did a literature search, and there was nothing. There was absolutely zero guidance, clinical guidance on how to treat them. And this was, about 10 years ago. So my group here got interested in the comorbidity between PMDD and bipolar disorder. We published just, some case series with some patients we had here that we successfully treated them with combining oral contraceptives to their mood stabilizers. So these are real cases, real patients. And then Mara, my former resident, and we wrote a piece on how to guide the clinicians on what to do when you face someone that has potentially comorbid PMDD and bipolar disorder, because you have to, obviously have a plan on, what will be the first and second, third steps in terms of treating this population. So we wrote a little piece for clinicians back in 2016. And then we developed a tool that, could track both the premenstrual symptoms and the mood symptoms concurrently, because, we're seeing a lot of comorbidities. So we call this tool McMaster Premenstrual and Mood Symptom Scale, MAC-PMSS. And this tool was developed with help of our patients. So patients gave feedback on the development of this tool. There were a lot of improvements and refinements. And I also sent to some experts in the area to get their expert feedback until we finalized the version. We wanted everything to be on the same page. So this is the mood tracking. So if people are feeling stable, feeling fine, they score in the middle. If they're manic, they score up. If they're depressed, they score down. And here are the cues about more severe mania or more severe depression. And here are the DSM-5 wording of symptoms that we model after the DRSP, which is kind of, the gold standard for clinical trials in PMDD, the daily record severity of problems. I know Tori and others have also now developed the CPAS, which is another tool that has been tested in research. So we follow the DRSP approach here with the 1 to 6. And then this is a person with, bipolar disorder and PMDD, but, they came on a mixed state. So you cannot see really the PMDD. So what we say in that previous paper is that you have to treat the bipolar disorder acute episode first. And then once you do that, then you can see, the premenstrual worsening here. Here's the bleeding, right? So the premenstrual period, the symptoms going up, the mood going down, and then eventually improving after the start of the menses, which you cannot see when the individuals are still on an episode. So I've seen a lot of patients that told me that they knew they had PMDD, their families knew they had PMDD, they went to their providers, even with the tracking, the provider said they didn't have PMDD because they couldn't see. But you have to understand that you have to treat the comorbid condition, and then you're going to see the PMDD comorbidity. So this is a case of a patient that gave me consent to present her case anonymously for educational purpose. So I blacked out the patient's name here. August 2021. This is a patient that I confirmed prospectively PMDD, and she also had, she goes by she, by the way, had a comorbid diagnosis of PTSD. So here's the bleeding, here's her own scoring, and you can see the symptoms going really bad and the depression. And then after she started bleeding, like she was feeling better. I started her on SSRI, and this is a month later, September. This is her tracking, bleeding. So premenstrually, the symptoms are still there. You can see some 4s and 5s, but way better than before. So partial response with only 1 month of an SSRI. And here is a day that was really bad for her. She wrote here PTSD. She saw her abuser and she got triggered. So the tool allows you to score life events, and then you can see when the symptoms get worse for other reasons that are not hormonal versus, hormonal reasons for worsening of symptoms. So patients ask, do you have an app? Like the paper, I lost the paper, my dog chewed the paper, and there were various reasons why sometimes the paper couldn't come back, the charting. So we now have an app. It's available in the iOS store. The Android version is in the works. We will launch hopefully very soon. But this is another patient of mine. This is a patient with confirmed PTSD, comorbid MDD, and as you can see here from the bleeding, the symptoms getting worse, 4s and 5s, mood getting down after the bleeding, symptom getting better. So this was her baseline track. And then after, she was already using an SSRI for MDD, so I added a hormonal contraceptive, and by adding the hormonal contraceptive to the SSRI, there was a partial response within a month. You can see the bleeding and the symptoms improving. Not yet perfect, but 3 is mild, so 2 is minimum. So significant clinical improvement with the addition of oral contraceptive. So wrapping up in probably 5 minutes. So what are the research gaps? So I think trauma as a risk factor for hormonal sensitivity is a major still gap, both in terms of mechanism and in terms of treatment. I showed you, many studies showing increased rates of PTSD individuals with PMDD. Nowadays, you're going to have a hard time finding any paper about any psychiatric diagnosis that doesn't have early trauma as a risk factor. Early trauma, it seems like changes the brain plasticity and render these individuals more vulnerable to developing all sorts of different types of, psychiatric disorders, later in life, including, it sounds like, increased hormonal sensitivity. So I think that's an area that requires some more work. I know Tori has been doing amazing, work in this space, and others are, but I think there's more to do. I still struggle with some of my colleagues asking me about, is this comorbid PMDD or is this just a premenstrual exacerbation? Well, I mean, if you read the attempt about 10 years ago, there was a consensus that was published, many of the world experts in the field try to publish a consensus about premenstrual exacerbation. And if I read that classification, it's not really, this is not a criticism. I think they tried their best, but I think clinically it's a hard, category to assist me as a clinician with my patients. So I think we need more work here. New treatments, selective estrogen receptor modulators. Can we have like safer treatments that also modulate the hormones without increasing risk for cancer, for instance? Neurosteroids is a fascinating area. Like we all know about GABA, we all know about allopregnanolone. So this is an area that certainly is like an amazing field. A lot of people are doing good research in this area, but we haven't found effective treatments except perhaps the allopregnanolone analog for postpartum depression that was published in the Lancet. Beyond that, for PMDD, I think some of the attempts have been, not that successful, unfortunately. Neurostimulation might be another area, as you understand the brain areas and the brain connections that are involved in hormonal sensitivity. Perhaps we can better place our neurostimulation targets. And to finalize the educational gap, the more gray hair I develop, the more, I scream and tables that I'm part of about we need to add, the reproductive mental health in the medical curriculum, in the psychiatric curriculum. I know I scan here in Canada, very few, medical schools and psychiatry residencies, they have, women's mental health as part of their curriculum. Unfortunately, a lot of physicians and psychiatrists, I'm saying that because it's my area, but I would assume it's not very different in many other, health professions that, the attention is not the same for this area as it is for other areas of medicine. So we really, really need to make a push about, putting this area in the curriculum, educational curriculum, because if we don't train people, the clinicians out there, they don't know how to properly assess, let alone treat this population. So how many people we are seeing that are seeking treatment and they're not getting the help that they need? What I'm saying here is not new. Here's already an almost 10-year-old paper in the American Journal of Psychiatry by Lauren Osborne and colleagues from the National Task Force for Women's Reproductive Mental Health. Here, this paper, they discuss beautifully about the educational gaps in the US. Here in Canada is even worse, I can tell you from my scan here. And I'm from South America. I know over there is not very much better either. So I think this is like something that there's still a lot of work to be done, because the result of that is what you folks here from the International Association for Premenstrual Disorders have done. This is a beautiful study from your own survey. Tori is involved, Dr. Lisa Hansu, I think I saw her in the chat here, and I have the honor to have you here. So, this is a beautiful study showing that, health professionals, no matter who they are, if they're primary care professionals, gynecologists, psychiatrists, or other mental health professionals, regardless of who they are, they're not doing a good job in assessment or treatment of these conditions. And even how patients rate their basic knowledge is very, very poor. So, and this is only 2022. This is a recent study. So this is our current reality. And I think for us to, not only we need to do like educational events like this one, like the seminar series that you guys are doing, amazing, and I have the honor to be here today, but we need to add women's mental health to the educational curriculum of all of these societies, all of these colleges. And with that, I'd like to thank you for your attention. This is my email if anybody wants to follow up with me offline and get the papers or have case discussions. I love case discussions. If you have other questions that I didn't have time to address here, we'll be always happy to. And thank you all, and happy to take any questions. So 45 minutes, perfect. We have 15 minutes for questions, so that's great.
Thank you so much. That was wonderful. I, obviously resonated with a lot of the points you made. I think just this difficulty in the disconnect between PMDD and PME, and how, we sort of usually actually see a mix of those things in I would say the most common presentation that we see, especially when we try to use things like the CPAS to pull out symptom by symptom what the pattern looks like. It just looks like most people have at least one psychiatric comorbidity. If they're coming to us, talking about PMS, PMDD, and most of the time, at least some of the symptoms of that comorbidity are chronic but worsen. And then most of the time they have some symptoms that are, not present in the follicular phase, and then present in the luteal phase, or present in the perimenstrual phase, and then go away again. So, even talking about categories of people kind of falls short of the way we see it in the clinic, right? Where it's actually symptom by symptom, we see differences. And I know Sally Hartledge, published a paper talking about that a long time ago as well. So how do we serve people with this diagnosis when actually it's sort of a mixture of things many times? And then of course, I think I'm biased, but I think that the you talked about the temporal subtypes paper, and we have a theory paper coming out hopefully soon, called the multiple hormone sensitivity theory, that's based on that and the other work that we've done. And really saying, we need to try to validate biological subtypes of cyclical change and hormone sensitivity generally across the lifespan, because then maybe, getting to something else you said, we can do more targeted treatment approaches. Like maybe that's why the neurosteroid approaches haven't worked in PMDD, right? Maybe it's going to work for a subset. I think about the sopranolone trials from Azarina Pharma, which everyone we're so excited about, including me. And, it looks in their data, like if they separate out sort of some of the depressive phenotypes, then they get a better response, right? So is that sort of a subtype thing? So anyway, all of this, makes this work really difficult, but I think also makes it very interesting. And I hope that some of the trainees and the audience today are kind of inspired by that. So anyway, that's just sort of my comments, but thank you for highlighting all of that, and just wonderful talk. Let's talk about a few of the questions here. Kathy Stewart says, hi, are there any studies that show the impact of treatment of trauma and the effect of that treatment on PMDD? I'm not aware of any. Do you?
Yeah. So this is actually an area that we are going to explore. I have a wonderful new postdoc and a new PhD, clinical psychology student that are both interested in exploring the, new psychological treatments that incorporate trauma-based therapies with, DBT and other things that these individuals often need, with the biomarkers, also that Tori rightly said that I'm also biased towards, the biological aspect of it, of course. But so because I'm biased towards the biological aspect, I'm bringing people that are going to, enhance the psychological aspect of it, including the trauma as an example of it, to hope to expand and improve that knowledge. I'm also unaware of it, but definitely I know we are not the only group that is now investing in this space. So I think unfortunately right now, what we have is, the mainstream treatments for, acute stress disorder, PTSD, emotion dysregulation. I don't like the term borderline personality. I call that emotion dysregulation disorder, but but so-called borderline personality disorder and other things that can be related to trauma. But certainly an area that needs to be developed in the space of hormonal sensitivity. How that interface of the trauma that happened, back in the days, there's still impacting people's mental health and the hormonal sensitivity aspect. How can we develop treatments that can address both? So I think this is the clinical challenge that us here and others are up for. But with the caveat that I'm not the expert in that field, so I often put myself in I sometimes do that to myself so I can learn. So I'm with you. I need to learn that space as well, and I'm excited about what's coming.
Thank you. Yeah, we have a paper under review right now by my grad student Anisha Nagpal, where she shows that in a pretty large data set, transdiagnostic data set from the baselines of our clinical trials, we see a pretty prominent relationship between life stress exposure and cyclical symptom change, including suicidality symptom change across the cycle. So not just levels of symptoms being higher because there was exposure to stress, but the degree of reactivity to hormones. And I think a lot of those papers historically have been rather small or based on retrospective report. And so, to have a really nicely powered demonstration of that, I think is hopefully going to be a nice addition to the literature. Another thing that she found didn't pass multiple corrections, but that, it was actually recent life stress, at least in our sample, that mattered more for sensitivity as opposed to childhood, which, we'll have to replicate that. But if that's true, that's actually a promising, a good news, right? Because it means that if we treat the sources of stress right now, if we could get that threat system under control, maybe that would reduce hormone sensitivity. So anyway, I just wanted to share that.
Yeah, and one thing that it's promising here we're seeing is a trial of real-time neurofeedback for PTSD. That in fact this is a funded work from my colleague and collaborator from Ottawa, Dr. Andrew Nicholson, and his PhD student John Lieberman. So they found in the neuroimaging, hubs that are disrupted in individuals with PTSD, and then now they're putting people on the scanner real time, and then using those ROIs to prompt. So individuals are seeing their areas of interest being overreactive in the scanner, and they're using their own mental tools to decrease the activity of their own brain. And then they are measuring PTSD symptoms over time, and they're already seeing improvement.
Oh, wow.
With a real-time neurofeedback. So this is something that, and this is in the space of PTSD, right? So why am I involved in that? Because I want to bring that closer to the hormonal sensitivity subgroup of individuals that have that, both the trauma and the hormonal sensitivity, and see if in the future we can have like a non-pharmacological approach to those individuals. That's why,
fascinating.
it is really cool.
Wonderful. Another question. Elizabeth says, where can I get a copy of the McMaster premenstrual and mood symptom scale?
Yeah. Just email me.
Email him. Okay, wonderful. And I think he said also that the app is on the App Store for the iPhone.
It's on the iOS. Yeah. It's
and will be coming out for Android, hopefully coming down the pipe.
Yeah, the Android, so we had to update, and then when we update the Android version that was working bugged. And then so the iOS is fine, but the Android we are working on.
Yeah, apps are a lot to make and maintain. So that's wonderful.
Yeah, but the cool thing about the app is that there's a share button there. So individuals, they fill their monthly questionnaires, and then they press share button, and then they choose, email, text messaging, WhatsApp, whatever, platform they want to share their calendar. So I received those for my patients by email before their follow-up visit. So I have, the calendars in front of us for discussion.
Great. That's great. All right, next question. Hello, do you know of any studies that are examining neurodivergence, specifically autism and ADHD, alongside PMDD?
Yeah, so autism, I'm not aware, but not because they don't exist. I haven't, done my part in terms of reviewing. I did some literature review on ADHD not that long ago, And ADHD, from what I understand, there is not really a great deal of increased link. Of course, some people will have a diagnosis of ADHD and will have a diagnosis of PMDD. They can coexist. Those people, they do exist. But in terms of greater risk, of a high risk of ADHD in this population, like we see in mood disorders and PTSD, there has not, I haven't seen like a major
So
link with the little
there
little
isn't, yeah, there isn't anything, but we're finishing up an R01 at University of Kentucky that I'm a co-I on, basically following adult females with ADHD across the cycle, a big sample, and really getting daily ratings
yeah,
of all of their symptoms and cognitive testing and all of that. So I hope that in the next year and a half or so, we'll have a big paper and we'll see,
yeah,
how common it is both, to have that comorbid affective change like
yeah,
PMDD, but also to have how common is it that the executive functioning difficulties that people
yeah,
with ADHD have, how common is it that those worsen? So that'll be a really interesting, I'm excited to do those analyses, but that's coming. And then I'm a consultant on a grant looking at the effects of puberty on
yeah,
autism, and Blythe Corbett at Vanderbilt is doing that. And I know I've had her add in some monthly questions for the parent, usually the mother of the female with autism. And one of the questions we asked a series of questions about whether the mother has noticed, or the caregiver, but usually 99% of the time it's the mother, has noticed premenstrual emotional symptoms, and how much are they impairing for the girl with autism. So that'll be really interesting to see if we see
mhm,
anything from that. It's kind of early, kind of an initial way to look at it, but that'll be interesting. But I agree. I don't think there's a lot out there so far.
yeah. I haven't seen like a strong link when you compare individuals without it and seeing that greater risk. Yeah,
I don't think, but I just don't think the studies are
yeah,
out there. Okay, how can we tease apart history of other mood and anxiety disorder
yeah.
from previous misdiagnosis of PMDD?
Tracking.
Yeah,
With the tracking. I'm useless without the tracking. I tell the patients that, they have to do the tracking for me to be accurate and for them to be accurate with themselves. The tracking is the only way we can tease those apart. So that's why this prospective daily chart is so important. And that's why we developed the one that has both mood and premenstrual symptoms in the same sheet. So you can see the dynamics of both mood and anxiety symptoms, because the PMDD also has some anxiety symptom. There's the anxiety
right,
question there as well. But then once you understand the trajectory of those symptoms over time according to their menstrual cycle, then you can understand way better what's hormonal, what's not hormonal. And then the reality is that a lot also comes after when you treat them. Let's say you use lithium for someone with bipolar disorder. Lithium is known not to work for PMDD. It's known like it doesn't work for PMDD. And then if you see that's dramatic improvement, in the premenstrual phase, it's likely that it's treating the bipolar, and there was, in retrospect, maybe a premenstrual exacerbation, right?
interesting. Yeah,
Versus comorbid PMDD. So a lot happens also after the treatment, which again, I tell my patients, I need the 2 months, not just for the diagnosis, but I need now the several months following the treatment
right,
changes, because each time you change the treatment, you need to continue doing the tracking, because the baseline gives us, very important information about diagnosis, but also gives us very important information to compare in terms
right.
of the other treatment modalities that we try. Because if for us to really understand the treatment improvement, we need to compare the future tracking sheets with their baseline.
Yeah.
So the
Do you have,
tracking is important throughout.
yeah, do you have any kind of words of advice for clinicians who might struggle to get their patients to fill out the trackers? I know that I personally have had pretty mixed experiences with
Yeah.
patients. I really try to emphasize the importance of it, but it seems to kind of, for some people, come easily, and other people, they just really struggle to do it.
Yeah. So one of the things that sometimes we use successfully was those people that have good family support, asking the family member to be committed to the tracking,
Yeah,
to assisting the person doing the tracking. So having almost like another person in the treatment to assist with that, like a family support to do that. The app has a notification that you can set up. So you can ask the app to give you a prompt. You can choose the time of the day. So if it's easier for you in the morning or at nighttime or midday, you can choose, and then the app can send you a nudge. Have you done your tracking?
right,
And you can set that up according to your own needs. So that helps some people just remembering to do. And then the app allows 7 days back, but
okay,
not more than that. After
yeah,
more than 7 days, then it's locked, because you can't. Then it becomes a retrospective tool.
right, right.
But
No,
most of
that's
but
a nice range. Yeah,
yeah, most of us know how our symptoms were like yesterday or the day before, but not April 28th, unless it was my birthday, right? So yeah.
yeah, yeah. Wonderful. Well, I have one final question for you, if you have a second. The irritability that can be associated with bipolar disorder, how
Yeah.
do you differentiate that from irritability in PMDD?
Again, with the tracking, right? So
But if they're
irritability
the
is,
same symptom, like, does that make it difficult, or?
yeah. So, challenging cases happen, for everybody. All of us have cases that are very difficult to understand and ascertain and all that. So, but for the most part, for most cases, doing the tracking can help us differentiating, you know, whether or not the exacerbation of that symptom, irritability, for instance, is it happening premenstrually? Is it happening during ovulation? What's their baseline outside of
Right,
these areas in the menstrual cycle? Do they have emotional dysregulation? Do they not? What are the other factors that can be associated with irritability? And then, as I published in the paper in 2016, you have to treat the acute mood episode first.
right,
That's my opinion. So you treat the mood episode first, get that irritability down from bipolar disorder, and then presumably with the tracking, you see if there's any PMDD or
right,
ovulation related, peaks of irritability that you can then with more certainty say this is probably hormonal and
right,
not from the
right.
baseline bipolar disorder. So
Yeah,
both tracking and also, treating the mood episode first.
yeah,
Get that out of the way.
yeah. Well, thank you. This was wonderful. I really enjoyed it. I hope all of the rest of you did too. And we just really appreciate your time, Dr. Frey. And yeah, we'll see all of you soon.
Thank
Thank
you.
you
It's a
so
pleasure.
much.
Thank you, all, everybody. This has been an incredible experience. I appreciate it. And
Wonderful.
and great job, IAPMD. I'm a lifetime member now, supportive, and this is a great. You guys are doing something fantastic.
Thank you
Thank
so
you so
much.
much. Thank you for being here. Really appreciate it. Thank you,
Yeah.
everyone. Take
Thanks.
care.
Bye,
Take care,
everyone.
everybody. Thanks.
Bye.
Bye bye.